So we'll get started by speaking on Mycobacterium tuberculosis. This was discovered by Robert Koch in 1882. It remains one of the most common infectious causes of death in adult patients, and the human host serves as the only natural reservoir for TB. The ability of the organism to efficiently establish latent infections has enabled this mycobacterium to spread to nearly 1/3 of the world's population. It is estimated that around 9 million new cases of active TB occur each year. Around 1.7 million patients die. Disease incidence is magnified by the concurrent epidemic of HIV, and a large number of patients have multi-drug resistant tuberculosis, which means that the tuberculosis is resistant to more than one anti-TB drug. And there are 57 countries that have reported at least one case of what we call extensively drug-resistant tuberculosis. There are some cultural beliefs that have been associated with TB over the centuries. It has acquired a multitude of descriptions. The captain of death, wild plague, white death have been names given to describe tuberculosis. Because this is an infection that's transmissible, TB inevitably reduces the patient to a state of isolation. Those patients are kept on isolation from the rest of the family, or even in the hospital we put them under isolation, and so it does have a social stigma. Avoidance by members of the community for fear of contagion and termination from jobs because of the illness is also a major problem with tuberculosis. These are some of the estimated numbers. If you look at the globe, the darker the color, the higher the number of cases per 100,000 population. And as you see in some areas in Africa, particularly South Africa, Southeast Asia, Western Africa, there are many countries that have very high rates of tuberculosis. Another thing that we track typically is the rate of multi-drug resistant or MDR tuberculosis. And as you see here, a large part of Eastern Europe belongs to the dark blue, which means that more than 18% of cases of tuberculosis are due to multi-drug resistant TB. Now, these can be very challenging to treat because we don't have too many options to treat the MDR, and mostly the what we call XDR or extensively drug-resistant TB. Let's now talk about TB in Lebanon. This remains a significant public health problem. There are many demographic changes that have led to the increased number and rates of tuberculosis in Lebanon. As you know, we have a large number of workers, domestic workers, who come from countries that are highly endemic for TB, Ethiopia, Sri Lanka, Philippines. These are all countries with high endemicity for TB. And more recently, with the influx of Syrian refugees also, some of them brought with them active tuberculosis, and we've seen a rise in the number of TB cases in Lebanon. So Lebanon is no longer classified among countries with a low incidence of TB. These are some of the numbers to reflect the fluctuation over the past few years. And again, as you see, some years we have more reported cases than others. But important to recognize that in more recent years, the number of non-Lebanese in Lebanon who had tuberculosis is higher than the number of Lebanese. So the percentage of non-Lebanese to Lebanese is 53% in 2015, and this is believed to be even a higher ratio in more recent years. In talking about susceptibility of tuberculosis in Lebanon, again, we have fluctuation. This is just to show you that we have some ongoing research to track the susceptibility of TB in Lebanon. And obviously, you don't need to memorize any of these numbers, but just to give you an idea of what we do in terms of tracking susceptibility to which anti-tuberculous drug. Now, let's talk a bit about how is TB transmitted. As you see here, the majority of cases are acquired through the respiratory tract, and it is well known that Mycobacterium tuberculosis is transmitted via airborne droplets. These are very small particles that are created by coughing, sneezing, or even talking that are spread through the air from an infected person, and they remain suspended in the air for a long time, and anyone who gets in contact with these is called a contact to an active TB case. Other routes of transmission can be the gastrointestinal. This is not very common, but we see sometimes people acquiring intestinal TB from consuming unpasteurized milk. In some cases, when a person is exposed to a case of active tuberculosis, we call that person a contact. If the person's immune system is able to remove the bacteria totally and the contact does not develop an infection, then that would be it. It means that that person was lucky, they were exposed, but they did not end up developing any form of tuberculosis. In other cases, the person develops an immune response that controls the bacteria by walling it off inside the body and causing the bacteria to become dormant. This is what we call when we say someone has dormant TB or latent tuberculosis. It is when their immune system has been able to wall off the bacterium and they did not develop any symptoms. Microbiology, Mycobacterium tuberculosis belongs to the genus Mycobacterium, and there are more than 50 other species we refer to as either non-tuberculous mycobacteria, NTM, or MOTT, Mycobacterium other than tuberculosis. TB is defined as a disease caused by members of the Mycobacterium tuberculosis complex, including Mycobacterium tuberculosis as well as Mycobacterium bovis. This is a slide showing the structure of the Mycobacterium tuberculosis. You have the cell envelope composed of a core formed of covalently linked peptidoglycan, arabinogalactan, and mycolic acids, anchored to the plasma membrane formed by lipopolysaccharide and lipoarabinomannan. It gives the mycobacterium its characteristic staining properties. Sometimes the mycobacterium can stain positive with a regular gram stain that we use for other bacteria, but the mycolic acid structure confers the ability to resist destaining by acid alcohol after being stained by certain dyes, and this is why we call the stain acid-fast bacillus, AFB. This is an image that shows how the AFB smear can show the organisms under the microscope. What are the risk factors for a patient to develop tuberculosis? Some of the risk factors are host factor related, others are social and environmental factors. The host factor related are listed here. Many of these are present in the patients we encounter, whether it's a malnutrition, injection drug user, systemic diseases such as diabetes, renal diseases, celiac disease, obviously HIV patients, as well as patients receiving immunosuppressive therapy, such as rheumatological patients or solid organ transplant. All these patients are thought to be at higher risk to acquire tuberculosis, as well as age and gender as listed here. Now, in terms of social and environmental factors, anyone who has a household person with TB, they're at higher risk to acquire tuberculosis. If someone is born in an endemic area, as I mentioned, Africa, for example, Southeast Asia are highly endemic. Community settings, people who live in crowded conditions, low socioeconomic status, and ethnic minorities are all risk factors for tuberculosis. But what are the factors that determine TB transmission? The more infectious a person is, the more likely TB will be transmitted to other close contact. Now, this depends very much on the burden of organisms present in the patient. Transmission is more likely to occur in small rooms with poor ventilation, and the longer the time spent, the more likely transmission to occur. So if someone is in a room with a patient who has tuberculosis, if that patient has a large burden of organism, as evidenced by a cavity in the lung, for example, and if they are together in a small room with poor ventilation for more than half an hour, 1 hour, the risk of transmission becomes much higher than in other scenarios. Poverty is known to be an independent risk factor to acquire TB, and there is a positive correlation which persists after adjusting for AIDS incidence, ethnicity, and proportion of foreign-born people. Obviously, poverty is very well known to be associated with malnutrition, and as I mentioned earlier, malnutrition is an independent risk factor for TB. Reasons behind this, not only malnutrition, poverty is associated with having people live in crowded homes, homelessness. They have less ability to engage, check their healthcare needs. They are more likely to engage in health-damaging behavior such as alcohol, drug abuse, and smoking, and more likely to suffer from comorbid conditions. Socially disadvantaged groups with higher rates of TB include ethnic minorities, foreign-born persons, unskilled industrial workers, prison inmates, and people with AIDS. What is the natural history of the infection, tuberculosis? Inhalation and deposition in the lungs of the tubercle bacillus leads to one of 4 possible outcomes. The first one is immediate clearance of the organism, and in this case, as I mentioned earlier, the contact will have nothing. The second one is the latent or dormant infection. The third one is a rapidly progressive active disease. We call this primary disease because this is the first time the patient has been in contact with tuberculosis and has developed symptoms. And the fourth type is active disease many years after the infection. And this can occur because of age, because of underlying immunosuppression, because of acquisition of an illness that will suppress the immune system. So there are many scenarios that lead to reactivation of TB later on in life. It is estimated that 5 to 10% of patients with no underlying medical problems who become infected develop active disease in their lifetime. Now, this is in normal people. So if a patient comes to you with a positive PPD and they ask, what is the likelihood that I will develop active TB throughout my entire life? You would say around 10%. But that assumes that the patient will not develop any immunosuppressant condition, will not receive steroid, chemotherapy, etc. If any of these occur, then the risk of having TB reactivated becomes 5 times more, 10 times more, etc. The majority of TB cases are going to be pulmonary tuberculosis, 85% of the cases. However, TB can affect any other organ system, including the pleura, the central nervous system, the lymphatics, the genitourinary system, even bones and joints, skin as shown here, and other organs. Latent tuberculosis. Let's start with this. During the stage of TB, the person is well and cannot spread the infection to others. So when someone comes with a positive PPD and negative chest X-ray, we tell that person you're not infective, you're not infectious to others. So although we might give you treatment for dormant tuberculosis, but you are not a risk for other people around you. If the person is treated at this stage, active TB can usually be prevented, and typically we say in 95% of the cases. What about primary disease when the patient develops symptoms? Tubercle bacilli establish infection in the lung after they are carried on in droplet. And as I mentioned, these are very small droplet, 5 to 10 micron, that reach the alveolar space. Now, 10% of infected persons only develop primary disease. 50% will do so in the first 2 to 3 years after infection. If the innate defense system of the host fails to eliminate this infection, the bacilli proliferate inside the alveolar macrophages and kill the cells. If the bacterial replication is not controlled, the tubercle enlarges and the bacilli enter the local draining lymph nodes, as you see in this image, where you have a large lymph node that sometimes they pop and they start draining pus from them. This is called lymphadenopathy, associated with tuberculosis, a characteristic manifestation of primary TB. The lesion produced by the expansion of the tubercle into the lung parenchyma and lymph node involvement is called a Ghosn complex. You will see that in your pathology course very well. And I think you have either taken it or you will take it soon. Bacteremia may often accompany the initial infection. However, we don't culture TB from the blood easily, and that's why we don't pick it up. This is what a Ghosn complex that becomes calcified will look on a cross-section. Ghosn's lesion takes about 3 weeks to develop. You have Ghosn's lesion plus lymphatic plus lymph node. In most cases, they heal by fibrosis and calcification. And this is where the bacteria can remain dormant for later when they reactivate. So this is if you do a chest X-ray on a patient, this is where you see a calcified lesion. Most likely the patient with this chest X-ray has had tuberculosis, has formed a calcified Ghosn complex, and the bacteria might remain there dormant if the patient does not receive appropriate therapy. Bacilli can continue to proliferate until an effective cell-mediated immunity response develops, which can take between 2 to 6 weeks after infection. Failure to do so leads to progressive destruction of the lung, developing of caseating necrosis, which is characteristic of tuberculosis. When you do any biopsy, whether it's from a lymph node, from a lung biopsy, or any other tissue. If bacterial growth continues to remain unchecked, the bacilli may spread hematogenously to produce what we call disseminated tuberculosis. What you see here is cases of miliary disease. The bacilli can spread mechanically. by erosion of the caseating lesion into the lung airways, as you see here in this top of the slide here. The host becomes very infectious to others, and if not treated, cases of disseminated TB can lead to death in 80% of the cases. Others will develop chronic disease or recover spontaneously. Now, why do we call it miliary disease? Because as you see on this bottom part of the slide, you have a millet-shaped distribution of the lesions. Chronic disease is characterized by repeated episodes of spontaneous healing by fibrotic changes around the lesion and tissue breakdown, and with time the patient will become more and more symptomatic with shortness of breath. And the fourth form is the reactivation of tuberculosis. This is when the patient is in contact with someone with active TB, they have no symptoms, but then the tuberculosis reactivates many years later. It may develop if latent infection is not fully treated. It occurs in 5 to 10% of people with latent infection, as I mentioned before, and typically we tell the patient around 1% per year, but this is just an estimate. If the immune system of the patient becomes compromised, there is a much more likely scenario where the TB will reactivate. And the greatest risk for reactivation is within the first 2 years following the initial infection. Reactivation disease, multiple terms have been used to describe the stage. The most common is TB reactivation. It results when the persistent bacteria in a host suddenly starts to proliferate again. The disease process tends to be localized with little regional lymph node and less caseation, unlike the case of primary tuberculosis. Lesion typically occurs at the lung apices, as you see on this slide, and disseminated disease is unusual in the setting of reactivation. It's more common to occur in the primary disease. There are many immunosuppressive conditions that are associated with reactivation of TB. I've listed few examples here: diabetes, HIV, end-stage renal disease, lymphoma, steroids. Potent reactivators of TB are the inhibitor of tumor necrosis factor alpha, which are now very commonly used to treat rheumatological diseases and some inflammatory bowel diseases. And as you see listed here is old age. Old age is an independent risk factor for TB reactivation. What are the clinical manifestations of tuberculosis? Let's start with pulmonary TB, primary TB. Fever is going to be one of the most common symptoms. As you see here, 70% of the patients have fever, and it can be low-grade fever or high-grade fever, up to 39 degrees Celsius or above. And it lasts for an average of 2 to 3 weeks. Most patients might go unrecognized and they are believed to have viral infection or bacterial pneumonia. They're given for fever and cough certain antibiotics. But when the symptoms persist for more than 2 to 3 weeks, I think we should always consider tuberculosis in the differential diagnosis. Some patients might develop chest pain, pleuritic chest pain if they have pleural effusions. Retrosternal and interscapular dull pain sometimes worsened by swallowing, and this is when the patients have enlarged bronchial lymph nodes. They feel there's pain as they are swallowing in their chest. Fatigue, cough, and arthralgias are non-specific symptoms that are present in TB as well as in many other infectious diseases. Physical examination, the pulmonary signs can be absent in many cases, and sometimes we find the crackles on lung examination, pain to palpation of the chest. Sometimes we find the decreased breath sounds by listening with the stethoscope if the patient has pleural effusion. But not all the time we're going to have abnormal finding on lung examination. With tuberculosis, unlike other classic bacterial infections, the symptoms are insidious and they can be present, as I mentioned, for weeks, sometimes up to for months if the patients go undiagnosed. Most patients have cough, weight loss, fatigue, night sweats in the setting of reactivation, and they may report chest pain, dyspnea, hemoptysis, as well as vague symptoms. Hemoptysis is when they spit blood after they are coughing. The cough can be mild and non-productive or productive of sputum. The sputum can be green or yellow, and sometimes the patient have frank hemoptysis. This is due to the caseous sloughing or endobronchial erosion, which can be present later in the disease and is rarely a massive hemoptysis. Patients can complain of difficulty in breathing, dyspnea when this is happening, when there is extensive parenchymal involvement, pleural effusion, or if there is a pneumothorax. All these can cause dyspnea in a tuberculosis patient. Not commonly, but we have seen sometimes painful ulcers of the mouth, tongue, larynx, or GI tract, and this is due to the chronic expectoration and swallowing of highly infectious secretions. This is a picture of what hemoptysis will look like on a mask that the patient was wearing when they presented to the emergency department. What are the complications of pulmonary TB? I mentioned the hemoptysis, the pneumothorax. As you see here, you have a separation of the parietal and the visceral pleura, which can cause significant shortness of breath, bronchiectasis, as you see in the lower part of the slide, and extensive pulmonary destruction if left untreated. I mentioned that the physical findings are not specific and can be absent in mild to moderate disease. And I think, if we look at the physical exam, the lung exam of the patient, you can hear crackles, you can have dullness by percussion if there is a pleural effusion. And clubbing, which is found on the fingers of patients with tuberculosis, is not specific to TB, can be used in many other chronic illnesses. But as you see here, is very characteristic of the chronic illnesses. And in the right clinical scenario, one should think about tuberculosis if the patient has fever, weight loss, pulmonary symptoms. What are the laboratory findings of patients with tuberculosis? They can have normal laboratory studies. Late in the disease, they can have normocytic anemia, leukocytosis, monocytosis. A drop in the sodium can be seen due to inappropriate ADH secretion, SIADH, rarely adrenal insufficiency in the setting of TB, adrenalitis, and hypoalbuminemia because these patients become malnourished with time, and hypergammaglobulinemia because this is a state of chronic inflammation from tuberculosis and the gamma globulins are expected to be elevated. Radiographic abnormalities are shown here. The most common is hilar adenopathy as early as 1 week after skin test conversion, and within 2 months in all cases you are expected to have some hilar lymphadenopathy of the chest as seen on this chest x-ray. The radiographic findings resolve slowly, often over a period of more than 1 year. For pulmonary infiltrates, they tend to be perihilar, and right-sided infiltrates are most common with ipsilateral hilar adenopathy initially. The infiltrates can progress within the first year after skin test conversion, so-called progressive primary TB, And then later on, this leads to the cavitation. As you see here in the lower part of the slide, you have a cavity. Once you reach a stage of the cavity, the patient is very highly infectious, and they are expected to have a high load of organisms in the sputum. How do we diagnose tuberculosis? We rely on smears and cultures. Typically, if we have a case of suspected TB, patient coughing, sputum production, we ask for a sputum acid-fast bacillus smear and mycobacterial culture. We plate the sample on Lowenstein media, as you see here in this image. All this has to be done under airborne isolation so that the laboratory worker will not be exposed to tuberculosis. It takes a long time of incubation for the mycobacterium to grow. Nowadays, with the availability of the automated machines to culture TB, we call them the BACTEC system, as shown in the slide. These are more rapid results. Sometimes within 2 weeks, we have the results of the culture. At AUBMC, we do simultaneously both the BACTEC and the Lowenstein media. And the smear, as you see, is quite characteristic. You have these long rods that stain in a red color on AFP smear. So in the right clinical scenario, if we see that on the sputum, this is tuberculosis until proven otherwise. TB PCR can be done not only on sputum, but in any sort of tissue, whether it's bone or skin or lymph node. It detects the presence of MTB as well as the resistance to rifampin. So typically you get the result saying MTB PCR present and rifampin resistance present or absence. And the great advantage is that you get the result in less than 2 hours. And the sensitivity of the PCR is very high in those patients who have a smear positive, culture positive result. So within 2 hours, you can have a confirmation of your diagnosis. How do we diagnose latent tuberculosis? We said latent TB patients are not truly patients. They are carrying the organism, but they don't have any symptoms. So we rely on a PPD, purified protein derivative. I think all medical students have this test done at the beginning of their medical education. The person who is newly infected, the skin test usually becomes positive within 4 to 10 weeks after exposure. And that's why if someone is exposed, we do a baseline when we see them first, and then we repeat the test around 8 to 10 weeks after exposure. It is performed by injecting a small amount of a solution just beneath the surface of the skin, as you see on this image. And this solution contains an inactivated portion of the bacteria, so there is no risk of causing any dissemination. Also, for patients who are going to be treated with anti-TNF therapy, for example, the rheumatology patients, we do a baseline PPD to exclude latent tuberculosis before we give them the anti-TNF therapy. And if we find that they are PPD positive, we give them preventive therapy before they start immunosuppressive therapy. This is how we interpret the PPD 48 to 72 hours after injection, and we don't look at redness, we look at induration, the size of the bump. And how do we call a PPD a positive PPD? It really depends on the immune status of the patient. First, let us all agree that anyone with a PPD more than 15 millimeter, we consider that as a positive test. However, if they belong to any of the other categories listed here, then a PPD of 10 millimeter or 5 millimeter might classify them as latent tuberculosis. So I take an example, a patient who is an organ transplant, if his PPD is 5 millimeters and above, I consider that as yes, he has latent TB. If I take a patient, for example, who has diabetes mellitus and a PPD of 10 millimeter or above, then I consider that as positive PPD. But for the normal people who have no underlying medical conditions, we require to have 15 millimeters to say they have positive PPDs. A positive PPD means that TB bacteria is in your body. It cannot tell you if you have active TB versus dormant TB. We need further testing to determine if a person has active or latent TB. And people who have active TB typically have, in addition to the positive PPD, some symptoms: cough, sputum production, weight loss, profuse sweating. Nowadays, there is another test that is available to diagnose tuberculosis. It's called the interferon gamma release assay, or IGRAS. It measures the release of interferon gamma after stimulation of peripheral blood T cells by the Mycobacterium antigens. It may be offered instead or in addition to the skin test. Now, obviously, this is a much more expensive test, and in Lebanon, we are still depending on the PPD as the initial test, because if it is positive, you do not need the IGRA test. But in some developed countries, for example, in many cities in the US, they use IGRAs instead of PPD because it only requires one visit of the patient and they don't have to come back later for reading. It's easier to interpret also for those who have received the BCG vaccine, because in the 10 years following the BCG vaccination, the patients might have some degree of positive PPD, and so the quantiferon can help you decide if it's positive or not. There are some recent guidelines that have recommended to do both at the same time. For example, for rheumatological patients who are going to receive anti-TNF, because both PPD as well as quantiferon can give false negative tests. This is how the quantiferon test is done, just to show the figures. If the TB test is read as positive, the healthcare provider will ask specific questions to see if the patient has any symptoms, and they perform a physical examination. We always obtain a chest X-ray to determine if the person has any evidence of pulmonary tuberculosis. This to manage the patient, but also for infection control practices. If these tests indicate that the person has active rather than latent TB, treatment regimen is different. So we treat active tuberculosis differently than we treat dormant tuberculosis. Pathology, as I mentioned, it shows caseating granuloma, and you will see that in your pathology section. Let's now move on to talk about the basic principles for treatment of tuberculosis. We need to provide the safest, most effective treatment in the shortest possible time. Because the Mycobacterium has the ability to mutate, we give multiple drugs to which the TB bacteria are susceptible, and we try to give it for the shortest possible time to ensure patient adherence to therapy. For treatment of latent TB, this is important as a TB control strategy in some low TB burden countries. Latent TB treatment, we give a medication to kill the dormant bacteria, and it greatly reduces the risk of the infection progressing to active TB later in life. And that's why anytime I diagnose someone with a positive PPD in my clinic, I advise them to take the therapy for latent tuberculosis. When the patients are giving the drug, we recommend to avoid drinking excessive alcohol and taking excess acetaminophen because of potential for liver toxicity. Now, this potential is much higher in older patients than in young patients. And patients should always be monitored for toxicity of medication such as liver injury. Now, there are multiple choices for treatment of latent TB. The first choice is to give isoniazid, 300 milligram daily or 900 milligrams twice weekly for 9 months. There are current studies that have suggested that even 6 months is effective and improves patient compliance. So now we have moved to give the patient without underlying immunosuppression 6 months instead of 9 months for latent tuberculosis. We give them pyridoxine, 50 milligrams PO daily. This is given to prevent peripheral neuropathy. There are other alternatives that can be given, rifampin 600 milligram daily for 4 months, as well as rifabutin can be given also for 4 months. Rifabutin is still not available in Lebanon. I would say in Lebanon, with the availability of the drugs, the cost, etc., our preference remains isoniazid 300 milligrams daily for 6 months up to 9 months, depending on the patient's scenario. Now, when the patient has active tuberculosis, the treatment regimen is very different. To make this easy to remember, typically for a pulmonary TB case, we give 6 months of treatment, 4 drugs for 2 months, and then 2 drugs for 4 months. 4 for 2, and then 2 for 4. If a patient has meningitis, there are additional drugs that we add because we want to give drugs that penetrate the blood-brain barrier. And although 6 months is what's recommended for TB in the lungs, TB in the lymph nodes, there are some cases that require much longer treatment, up to 12 months and sometimes longer. The 4 drugs that are still considered first-line therapy for TB include isoniazid, rifampin, pyrazinamide, and ethambutol. And as with treatment of latent tuberculosis with isoniazid, we give pyridoxine 50 milligrams daily. There are drugs that we give also for multi-drug resistant tuberculosis. You don't need to remember these drugs except just to have a look at them so that if you see them mentioned somewhere, you know that there are some choices that are available to treat multi-drug resistant TB. And typically this happens in a directly observed therapy, which means either the Ministry of Health sends someone to the house or the patients get hospitalized because this is a public health risk and we don't like them to be out so that they don't transmit the MDR TB to other patients. And the last part of the talk is prevention and public health related issues because tuberculosis is a highly infectious organism. So persons with active TB of the lung and throats are considered infectious if they are coughing, if they are undergoing cough-inducing or aerosol-generating procedures, if they have sputum smears that are positive for AFB and they're not receiving therapy, and any patient who is just diagnosed with active TB, they are considered to be infectious when they have TB in the lungs until they have been on therapy for at least 2 weeks. And so typically what we do is we start the patient on therapy, we repeat their AFB smear after 2 weeks, and when the AFB smear becomes negative, we can tell the patient that you no longer need to be on isolation. How do we protect ourselves from tuberculosis? When we are in close contact with a person with infectious TB, we wear a mask called N95 mask, and this N95 that you have seen now being used for COVID-19, it does prevent 95% of the particles to be inhaled. Typically the patients are placed in private room with negative air pressure, which means that the air comes from outside to inside the room and not vice versa, because you don't want the air from the room to circulate in the corridor and goes to other rooms. The air should flow from the hole into the room with 6 to 12 changes per hour, an appropriate discharge of air outdoors. The door should be closed, and there are now HEPA filters that can be used to exchange the air. We limit the patient transport, and if a patient needs to be transported outside his room, the patient wears a regular surgical mask and not an N95 mask. So let's agree on that. The N95 masks are for healthcare workers. If the patient needs to be moved out, needs to leave his room, then he would wear the regular surgical mask, but not the N95 mask. Private room with negative pressure, we mentioned that. Okay, and what about TB vaccines? As you know, the BCG, which some of you have taken, has been shown to decrease the risk of severe forms of TB in young children, but has not effectively altered the adult form of TB, which really remains the primary source of transmission. And that's why in many developed countries, including some developing countries such as Lebanon, the BCG vaccination is no longer practiced. There are now more than 10 vaccines that are being used in research, and hopefully within the next few years we will have an active TB vaccine, particularly that now we have started to see more and more cases of MDR and XDR TB.